There we go. So thanks again for having me this morning. Sorry about the technical issues. This is the first time I've given a presentation in a webcast format like this. I'm going to talk to you this morning about the NIH common data elements for Chiari. And I want to frame this for, first of all, why do we undertake this project, and a little bit about what the benefits of the project are and what we hope that people will get out of all the work that's been done on this. So I'm going to start out with a little bit of a case presentation, just to frame the thought process here. So this is say a 10-year-old boy. You can see his tonsil position about 10 millimeters below the foramen magnum, and he has a large cervical syrinx, or simply a cervical thoracic syrinx. So we posed a question in a survey several years ago to the members of the American Society of Pediatric Neurosurgery. What would you do in your practice with this patient? What would you do if the patient was asymptomatic, or if he had different questions for what different symptoms this patient might have? And the interesting thing was that we got a fairly wide range of responses from we would operate on this patient regardless of whether he has symptoms or not. Although if they're asymptomatic, you'll see that there's a contingent of surgeons who would argue that that patient didn't need surgery. Versus if they had headaches or other symptoms, you see people get more and more likely to offer an operation. And there's different options for what operation these folks would offer. Now that's all to a fairly clear clinical scenario, a patient with neurologic deficits, with a Chiari and a syrinx. There's not a lot of debate in the community about whether that patient needs an operation. And here's this paper that I'm referencing here. It's a little more challenging if you have something like this. Right now we have a child who has a Chiari malformation, no syrinx, and how does the discussion play out about surgery or no surgery based on what symptoms this child might have? And we all understand that there are many problems, many other comorbid conditions that are seen in individuals who have the imaging finding that's consistent with Chiari that can really muddy the picture. We have no good, we're struggling still as a community to have a good idea of what to do. Am I still on here? Sorry, I just got a very confusing text message from Paulo. Paulo's not answering on the phone here, so I don't have any way to get feedback from you, so I'm going to just continue with the presentation. At any rate, Chiari itself, as we know, is a very common problem. In the adult population, in a study done in the Netherlands of over 2,000 adults, about 1% of the general population had tonsil position below 5 millimeters. And you're probably familiar with the Michigan MRI study of over 14,000 children who had MRI scans for various reasons, where they found a prevalence of tonsil position below the foramen magnum up to 3 or more than 3%. So what we have is a complicated scenario that can lead to a lot of different clinical symptoms and something that's actually quite common in the population. Which leads us to these big questions. What is the natural history of Chiari malformation? Can we identify patients who are at risk for clinical progression? Who's going to get worse with these imaging findings that are consistent with Chiari? What are the key anatomical issues that generate symptoms and deficits in Chiari? And how can these symptoms that come from a Chiari malformation be differentiated from symptoms that result from other things, perhaps like mast cell activation syndrome, which we just heard about, that potentially are unrelated to Chiari? And then from the surgeon's point of view, who should have treatment, and how effective is this surgical treatment? So I would argue that a lot of these questions are almost unanswerable based on what's in the literature and the research methodology we have. So the question, how can we study this complex condition? Now, one way to go about it is by using big data, large registries, pool a lot of patients, a lot of data together, a lot of information, and oh, very good. I got a message saying I'm doing okay. Yeah, very good. Sorry about the confusion. These registries, these studies that are displayed here are a good effort. They're a good they're good methodology to try to answer some of these questions. However, to date, most of these big registries have focused on patients with Syrinx, not necessarily just with Chiari. They've had fairly strict inclusion criteria. And to answer those questions about the individual with symptoms that are unclear whether they're Chiari related, they don't have a big Syrinx, these aren't going to do the trick. So we need something more. We need a way to define the symptoms, we need a way to define the outcomes, and we need a way to describe Chiari and all its related conditions. Now, if we're going to do this in a systematic fashion across a broad Chiari community, we have to be speaking the same language. And to do that, step one is to create a common language for Chiari research. And that's what we've done, or what we've attempted to do with the NIH Common Data Elements. So the NIH is, as you know, the National Institutes of Health. One of those institutes is the NINDS, or the National Institute for Neurologic Disorders and Stroke. The NINDS has put together a Common Data Elements project. This has been going on for many, many years now. The idea being that researchers that focus on a certain neurologic problem come together and define variables and standardize the way that these variables are reported, then that can help investigators conduct clinical research using these variables, and it can systematize the way that the variables are collected, which makes analyzing them and potentially combining them and sharing them in the future much more straightforward. So if we're all speaking the same language, then we can pool our resources. Even if each of us has done an independent research project, we could potentially pool the results at a later time. So why is this important? Well, if there are a number of different clinical trials and research studies ongoing, and they each use each of them have historically in the past designed their own case report forms. They've defined variables that they want to study, and these variables may be similar across studies, but subtly different. And that difference makes it impossible to pool data and compare their outcomes. So with the CDE approach, the Common Data Element approach, this has the potential to make it possible to systematically collect these data and share them. It also has the potential to decrease the startup time and effort at the beginning of a study. If all the variables that one might want to study with regard to Chiari, for example, are already defined and available, then it's quite a bit more simple to get your research project going. I like to think of this as a buffet. So if you're a researcher working on Chiari and you want to think about certain questions, then you come to the CDE buffet of research instruments and variables, and you pick out the ones that you want to use in your study. You certainly don't have to use them all, and that'll facilitate both getting your study started, getting it going, and also using these data in the future. So what specifically is a common data element? We'll break it down into its components. So it's really quite simple. One, it's the name, the semantic value, or the actual name of the element. Number two, it's a clear definition of what this element is, what this variable is. And that's what actually ends up taking a fair amount of the time and effort to defining these. And finally, it's a list of permissible values. When you include permissible values, what you're doing is doing front-end data control assurances. If the researcher is only allowed to put certain things into this field, then you know you're not going to get gibberish answers. Now here's an example. Now this is one that's applicable across essentially all diseases. So the name of the CDE is disease initial diagnosis year. What year did your disease get diagnosed? You see the definition there, the year a physician first diagnosed the disease, and you see that it's got a limited field where what you can put in it. It has to be a 4-digit numeric value. So the objectives of this CDE project, as we said, identify CDEs that are going to be used in clinical research for a given disease, and in our case, Chiari. Present all the data elements in a standard format that's then available widely and for free for everybody to use. We identify common definitions. We group these CDEs, group these data elements and variables together onto case report forms and case reporting instruments. These are things that logically would flow together. A bunch of different variables together on a form makes it easier to start your study. And then provide information to researchers to help develop databases in the future. This is a little bit outdated now, I think, but here are some of the diseases for which NINDS has already completed their CDE effort. The ones in black are the ones that are done and published, available on the website. The ones in blue are planned, and the one in green there is under development already. I actually think spinal cord injury may be finished by now. And we've gone over this already. The impact of the project, really multifold impact. If you can get this done and done well, there's a host of benefits that the whole community can reap. So how does this process work? Well, the CDEs themselves have to be identified, developed, and vetted by experts in the scientific community. So for Chiari, we've got to get together a host of different stakeholders, both physicians, surgeons, neurologists, radiologists, immunologists, and everyone who may have a role in the Chiari community, as well as individuals with the condition, and try to define these variables, make sure that it is transparent and inclusive. And we have, of course, some support from the NINDS to do this. Now, ideally, the version that is the end product of all this work is not the final version. What's published is dynamic, and it will evolve over time. As people start to use these data elements, they can change, and we can notice and uncover problems with the way things are worded, for example, or new data elements that weren't included. And so there's an ongoing effort to refine and reprocess these CDEs. Here's that same process in a graphic schematic. So first we develop recommendations on what they should be. There's an internal working group where we put together everything, and then finally these get posted for public review. And once the public commentary is all addressed, they get posted for public use. I'm going to speak a little bit about that public commentary phase a little bit later. But it's important that this is an iterative process. It'll keep going and keep being refined indefinitely. A little bit about CDE terminology. So the CDEs come in a couple of different broad categories. So one of these is the general core data elements. So again, this is an NINDS effort, so it's all related to neurologic diseases. So these core elements are those that are relevant across all neuroscience research. If you're doing a research project that involves anything in neuroscience, it would be logical to think that you would use these data elements. Obviously, these are very few, and most of them have to do with patient identifiers. So age of the patient would be an obvious example here. Every study is going to use that. Next, a little more specific are disease-specific core common data elements. These are the ones that are defined as, because they are core, they should be used in every study that studies this disease. So for Chiari, the question is, which of these variables do we have to include on every Chiari study? Something like the position of the cerebellar tonsils would fit this definition most likely. And the vast majority of common data elements are going to fit in these last two categories, which are disease-specific, supplemental, or exploratory. So supplemental, these are things for which there's reasonably good evidence that it's relevant to the disease population of interest. Exploratory, we're not sure if it's really that relevant, but it's got a possibility of a link, and there's reason why we should pay attention to it. And of course, these classifications can change over time as new knowledge is generated from new research. Here's our Chiari Common Data Elements team. It's a big group. There's, I think, over 75 people were involved in doing this. I'm not sure all of their names even are included here. Here was our process. So this all started at a meeting in San Francisco in the spring of 2013. And I can tell you that just this spring, we finally got these uploaded and published on the NINDS website. So this happened over a 4-year period. We started together by defining the different working groups. Instead of trying to just as a group consider all the data elements that you might want to think about with Chiari, we broke it down into these categories: demographics, presentation, comorbidities, imaging, treatment, and outcomes. The meetings were held in person twice a year, and then via various different conference call strategies essentially every week. And we went through this in the same kind of iterative discussion: identify the element, define it, refine it over and over again until we have consensus on how this should go. Here's an example of what, for each data element, all of these categories need to be filled out. So you see the name of the common data element, the definition, the list of permissible values or permissible data types, additional comments. I'll give you an example of that in a minute, an option for putting in the reference and where did we get this information, what's the literature support for the use of this data element, and then that classification: is this a core, a supplemental, or an exploratory data element? And here's again one example with tonsil position. You see we call the name of this data element lowest tonsil position. We had to think about this a lot. Could we call this tonsillar descent? Well, that implies that the tonsil has moved somewhere, when in all likelihood, in most cases, it's always been there. So we didn't want to call it tonsillar descent. We didn't want to call it tonsillar herniation, because that has a set of implications as well. We wanted this to be as broad and generic as possible. So the name of the CDE is tonsil position, defined as the tonsil position relative to the foramen magnum, and a list of permissible values. And then a lot of thought went into writing this definition, or these instructions on how to make this measurement. Actually, this is just an excerpt from the entire set of instructions. I'll show you more a little bit later. Again, this is an example of what we do for each of these CDEs. Fill out all of these data fields. So in the end, the group put together a total of 831 distinct common data elements to study Chiari. And that actually does not include the additional ones that we essentially borrow or commandeer from other neurologic disorders. Most of the demographics section, where you're describing the individual who has Chiari, how old, what gender, etc., that's of course already been done for other diseases. We assembled these 831 common data elements into 62 case report forms, and I'll show you a couple of examples of those. I'm obviously not going to show you all of them. But again, this is the researcher's buffet. If you're doing a project, a research project that has anything to do with Chiari, ideally you should be able to come to this site. You should be able to pick out all the variables that you want to use for a study and use them. If there's something that you want that's not available on our buffet, then there's a process for you to notify NINDS that something's missing and report that to the oversight committee so that it can be added in the future. Again, demographics, as I said, they were adapted from existing NINDS CDEs. This was by far the easiest part of this process. Nothing else was in any way easy. Dr. Kula was one of the main drivers in the presentation and comorbidities section. And this is a big challenge, because you've got to be able to capture in well-defined variable form all of the signs and symptoms that you might experience or associate with a Chiari malformation or a patient with a Chiari. So this includes, of course, the classic symptoms, the tussive headaches. It also needs to consider both specifically and in general any other frequent problems that might muddy the water. So headache is a great example. A classic tussive headache is going to be described one way, but a migraine headache is going to be described another way. There's, of course, dozens of different variations on how your headache with Chiari might present. So there's part of the reason that there's 831 CDEs is because a lot of this has to be very carefully spelled out. In addition, the presentation committee put together the neurological examination findings. A lot of those could be adapted from existing CDEs for other neurologic conditions. Some of them had to be defined. And then, of course, another big portion of this presentation and comorbidities section was the description of these comorbid conditions, things like connective tissue disorders, mast cell activation syndrome, and others. Whether or not they are clearly related to Chiari, it's not important. We need to be able to define them so that the research that might link them to Chiari in the future can be done. Let's talk a bit about the imaging CDEs, because this was the subgroup that I was personally involved in most intimately. These are almost all MRI measurements, at least the ones that we've defined thus far. So we had to talk about the ways to describe the tonsil position. We had to figure out ways to describe the morphology of the posterior fossa and the craniocervical junction. A lot of this comes from various published papers on the topic. Some of it had good literature support behind it, some of it didn't. But if there are conflicting opinions or conflicting definitions of a given measurement in the literature, then it's our job as the committee to reconcile those differences and come up with a consensus definition. Here's a case report form from the imaging group. You can see we've put together each of these numbers is one individual CDE. So this is a form that a researcher could use to right off the bat classify or characterize the imaging findings of a patient with Chiari malformation. Now, I promised you I'd give you more on tonsil position, and here it is. So we have painstakingly gone through a step-by-step process for how to identify the tonsil position and measure it. As you can see, I'm not going to read all of this, but nothing is assumed here. Where you draw the line to mark the foramen magnum, we've very clearly spelled out how to do that. And then we've also included recommendations on what are the best imaging sequences to make these measurements. That would be a sagittal T1 MRI or potentially a coronal MRI. Recognizing that you can make these measurements on a T2 MRI or on a CT scan, but they're a little bit more challenging. Here's another example from the imaging group on tonsil shape. So this is not a numeric variable, but a categorical variable. And potential responses here, recognizing how difficult it is to describe what the cerebellar tonsils look like in words, what we did for this was include example images. So these two pictures that I have on the screen here are actually they're actually published on the NINDS website along with this common data element. So there's an example of the pegged tonsil on the bottom, and of course the rounded tonsil on the top. So if you're trying to define or describe these tonsil shape, you can look at these examples. Where does the image that you're looking at fall in this? Well, it's either this, or in between. Again, there's not science to this, but this was the consensus from the working group about the best way to convey this information. Syringomyelia. A number of different data elements were defined for syringomyelia. So one is there a syrinx there? Yes or no? How long is the syrinx? Instead of trying to measure it in millimeters, we realized that it was probably makes a lot of sense to define it as the number of spinal segments, and so that's the way that CDE is defined. We put in different variables, different individual CDEs to mark the highest level of syrinx, the lowest level of syrinx, and the width. As you can see, with these, what is this, 5 individual CDEs, you can get a pretty clear picture of the size and scope of a syrinx. Moving away from imaging now to our next subgroup category was the CDEs to describe treatments. Now, most treatment for Chiari is, of course, surgical, but of course we also have to consider the other treatments that individuals with Chiari may be getting. So other medical treatments they may be getting for pain or for various associated conditions. And there's a host of CDEs that are existing now to describe these treatments. So then moving on to the surgery, if we're going to do robust research on Chiari, we need to describe all of the details of how you can do a surgical decompression, as well as the details of other common surgical procedures that may happen in individuals with Chiari. And the last group was outcomes. So one principle of the outcome CDEs is that we try to relate them to the presenting symptoms. If you had this symptom, symptom A at presentation, we want to be able to report how symptom A is after treatment. A couple of different established outcome scales included in this outcome group, and also, of course, a way to record any surgical complications, any problems that you may have had with the surgery. So a number of different CDEs here. In the end, this is where it all lives. So this is the web address for the common data elements at the NINDS. If you click this link, this is where it takes you. This is the NINDS Common Data Elements web page. And as you can see over here, the CDEs that are available, there's a long list. It's actually quite a bit longer than what's on the screen here, but you can click Chiari malformation, and that takes you to this page, where we have the working group has written an introduction to the Chiari malformation CDEs, and this is not an active web page, so I can't scroll here, but as you scroll down on this, you get to the various different lists of various different subtopics of Chiari CDEs. Now, as I mentioned, this is an iterative process, so we've now gone through the initial development, the working group review, the CDE construction, and then we posted for public comments. And one of the things that came really kind of struck us as we got the public comments back from from really the general public, there was a great deal of concern about the definition of a Chiari malformation, in particular how we were defining the imaging findings that could be considered a Chiari malformation. There was a great deal of pushback from the public on the notion that Chiari is defined by, for example, 5 millimeters tonsil position below the foramen magnum. We got feedback from individuals saying, well, if my tonsils are at 1 millimeter below the foramen magnum, but I have classic Chiari symptoms, do I not have a Chiari malformation? How does your effort speak to that? And the important point here is that this effort should not speak to that. Although the CDE process should be completely neutral, lacking in any kind of judgments or assigning of diagnoses. It just needs to be a way to report the variables and to report to facilitate research. And so we reworded a number of things to be responsive to this public commentary. And finally, CDEs are posted for public use and reviewed. This was the slide to remind me to tell you the story I just told you. So our next steps, the CDEs are always under review. The NINDS is now assembled a Chiari 1 malformation CDE oversight committee, and they will meet at least twice a year, and probably more frequently via phone calls, to review the CDEs, how they're being used, and what kind of ongoing commentary we have. In addition to that, our group, the CDE working group, has set off on a side project to test the reliability of the CDEs that we've defined for imaging. I showed you that imaging case report form earlier. We realized that if we've taken the time to painstakingly define how to make all these measurements, it would make a lot of sense if we tested these measurements to be sure that they are being made in a reliable fashion, and they can be made in a reliable fashion based on the definitions that we've written. So we've got an ongoing inter-rater reliability study of these imaging definitions that hopefully will be completed in the next couple of months and then out for publication. And of course, as an ongoing next step, we have to refine the definition of a Chiari malformation. I understand that that's a large part of the purpose of this meeting. The CDEs may not be tremendously helpful in that effort, but nevertheless, it gives you the tools to do the research that's going to be necessary to form the foundation for that discussion. With that, I'll end, and I'll take any questions. I very much appreciate your time and your bearing with me with this technically challenging presentation this morning. Thank you very much.